All right, so I'll give a kind of a very top overview of for the final exam, trying to kind of tell you what things to focus on. So starting off with the content of the exam before I get into it. So very similar to the midterm. This is going to be a like 100 questions, majority multiple choice, some true or false maybe. 50% of the 50 questions are going to be mine. 50 are going to be Dr. Visali's. I would say, if you really want to focus on, what is going to be the bulk for my questions, I'd say the blood and immune and the respiratory were kind of big. So I would say focus on those. There's going to probably be 80% of the questions are going to be from those two lectures, and then the last 20% would be divided between the endocrine and the risk assessment. So kind of try and put, again, don't hold those numbers, because it's not going to be exact, but I would say about maybe 20 questions on the blood immune, 20 to 25, maybe 20 to 25 on the respiratory. Endocrine is going to have less than 10, maybe like 5 or 6, and then the risk assessment, same thing. So I just want to kind of, again, guide you if you're kind of running out of time. What should I focus on in terms of? I try and know everything, obviously, but I'm just trying to kind of give you a little bit of hints. So if you look at the blood and immune, again, just this, started off with just what is the composition of the blood, talking a little bit about the different form elements and so on. Again, these are just the components and what the form elements are. All right, so if you look at this slide, I think this came as a question yesterday on the WebEx. Again, my point here is I just want you to understand, what each form element, what is the function of each form element, and in general, not to know the exact amount in the blood or their duration or lifespan, but just to kind of like know that the lifespan of an RBC is a lot longer than a granulocyte, for example, or agranulocyte and so on. But know the function of each form element. All right, so now getting into the toxicity of the red blood cells. So just know that the structure complements the function. Know the function of the erythrocyte. Again, know the basic structure of the hemoglobin, and that there's like 4 hemes, so capable of carrying 4 oxygen molecules. Now, know a little bit about the production of the erythrocytes. That, again, all the form elements come from the same stem cell, and then the regulation of the erythropoiesis, right? So what is the consequences of having an imbalance in the production or imbalance in the destruction of the erythropoiesis? Know that it's under hormonal control. And again, when you have like this imbalance in the oxygen level, what happens in terms of like stimulating the kidney to produce the erythropoietin that stimulates the bone marrow to enhance the production of the RBCs. So know the requirements for the erythropoiesis, and then a little bit about the fate and destruction of the erythrocytes, right? So, and this kind of slide kind of summarizes it all from the production to the destruction of the erythrocytes, and then salvaging some of the requirements needed to remake the RBC. Then I talked a little bit about the different erythrocytes disorders, the different types of anemias. So know the different types of anemias. So this is an important slide. So understand the characterization of each type of anemia and any examples of any drugs that I mentioned here. So know the difference between an iron deficiency, sideroblastic, megaloblastic, aplastic, and the agents that are mentioned on the slide as well. Now, talked a little bit about the hemoglobin function, the alteration in the hemoglobin function, and I want you to know the oxygen dissociation curve and the factors that can result in a right shift or a left shift in the oxygen dissociation curve. So know those factors that I mentioned right here and what really causes it to shift from, A to C with an increase or decrease in affinity to the oxygen. I mentioned, the alteration in the hemoglobin function, and I did mention the failure of mechanism to control the erythrocytes to reducing heme to the ferrous state, which results in this condition known as methemoglobinemia. And I want you please to remember that those examples. I mentioned those topical anesthetic drugs that could result in methemoglobinemia, as well as the nitrates and nitrites. These are preservatives in food that could result in that condition. So please remember those. Again, remember the heterotropic effectors of the hemoglobin function, can have an effect on the oxygen dissociation curve. Know that the thalassemias and what is sickle cell anemia, and then the alteration in the erythrocyte survival. So again, know a little bit about the conditions listed here, including the microangiopathic anemias, the exudative hemolysis, and how infectious disease could have an effect on the RBC, resulting in non-immune hemolytic anemia. And then also the immune hemolytic anemia, and the example of penicillin really resulting in the activation of the immune system that results in hemolytic anemia. So now moving from the RBCs to the leukocytes, to leucons. So again, know a little bit about the production of leukocytes. Again, the formation of the leukocytes and the differentiation of the leukocytes into both myeloblasts, monoblasts, and lymphoblasts. And then this is an important slide. So know the toxic effects on the granulocytes, so the agents that have an effect on the function, the proliferation, or could result in neutropenia. So all those agents mentioned here, please know them. Now I talked a little bit about the different types of leukocytes disorders and leukemias, and the characterization of leukemias, and more importantly, what are the leukemogenic agents. So please know those agents. Then got a little bit into platelets and hemostasis. So know again that what is the function of the platelet. Again, the genesis of the platelet. Again, all stems from this hemocytoplast, and it goes to the developmental pathway to form the platelet. The condition where you have destruction of platelets, the thrombocytopenia. So that's important. So please know that condition, including the condition of mentioned here, the syndrome, TTP syndrome. And again, no substances that prevents undesirable adverse effects, including the aspirin, heparin, and warfarin. Know the condition of hemostasis disorders, including DIC, disseminated intravascular coagulation, and then thrombocytopenia. And you remember I mentioned a lot that chemotherapeutic agents can cause depression, destruction of the bone marrow, so will have an effect on the platelets, but also can have an effect on the red blood cells as well as the white blood cells. Know the different types of hemophilias, which is hereditary bleeding disorders, and the deficiency in what blood clotting factors results. Deficiency in what blood clotting factor would result in that type of hemophilia. Now moving into the immune system. So know just the difference between the non-specific defense mechanism versus the specific defense mechanisms, innate versus adaptive immunity. So again, this is just just facts about the innate immune system or cellular response versus, again, the adaptive immune response, which is the acquired type of immunity. just know a little bit about the different terminologies that were used. And then the types of acquired immunity, whether it's naturally acquired immunity or artificially acquired immunity. And then, again, talking about the duality of the acquired immune response, I talked about the difference between humoral immune response versus cell-mediated immune response, and this concept of immunological memory that occurs after subsequent, initial versus subsequent exposure or secondary exposure, which kind of is summarized in this figure. This is kind of a nice summary to show you the difference between the cell-mediated immune response versus the humoral antibody-mediated immune response. Know the different types of hypersensitivity reactions, the type 1 versus type 2 versus 3 versus 4. So these are very self-explanatory, but I want you to understand the different types of hypersensitivity reactions. So these are, again, just know them and know the examples for each type mentioned here. And then autoimmunity. So what is autoimmunity? And also some of the chemicals or drugs that are mentioned that could result in different forms of autoimmunity. And then again, immunomodulation by xenobiotics, so know the examples that are mentioned here. And then at the end, what are the assays that you would use to assess immunity? So these are two assays I mentioned that looks at innate immunity, and then the difference kind of between tier 1 and tier 2. And I mentioned again, like you in general you start off with tier 1, which looks at more a general effect on the organs for the immune system. Then you move into like an assay that looks at the antibody formation, which is the plaque-forming assay, and then another assay for the innate immune response, and you get into specific assays in the tier 2. So that's the immune system lecture. Now the respiratory toxicology lecture. So again, just as the lecture outline says, I talked about the structure, function, pathogenesis of lung disease, and then acute versus chronic response of lung injury, then examples of agents that I want you to know, and then the evaluation of the lung damage using spirometry testing in a clinical setting, and then the preclinical studies that you do based on inhalation studies. So just, again, know the basic structure and the function of the lung, the upper airway versus the airway with the conduction region, and then the gas exchange region in the lung parenchyma. Again, the key thing is that how the structure really complements the function of the lung, the alveolus structure with the different type of cells, the pneumocytes 1 versus the type 2 pneumocytes. Then a little bit about the lung defense mechanisms that are available. With the immune cells that are present and so on. The vulnerabilities of lung to air contaminants. This is an important slide in terms of the absorption, the particle size I mentioned. You've seen that before in my first lecture on the exposure, but it's an important concept I want you to remember. Again, they're talking about the airflow and the different regions of the lung, which results in the method of deposition, where you have in the nasopharyngeal region you have very abrupt directional change of air movement and high air velocity, where the method of deposition is impaction, versus in the lung parenchyma, it's in the alveolar region, it's through diffusion. Know about the air-blood interface, and again how this thickening of the alveolar wall would result in an interference in the gas exchange. Know the lung defense mechanisms, and and this is just an example to the damage to the mucociliary escalator, and how like the macrophages resident in the lung could result in an oxidative burst, which is a defense mechanism, but again could lead to pathological changes if there's an imbalance that would result in eventual kind of like inflammation and pathological change. Know the function of the surfactant and what, why you need to have the pulmonary surfactant and what happens when you dilute that surfactant, or, where it kind of results in lung collapse and the conditions that could result in that. Now, talking a little bit about the acute responses to lung injury. So I want you to know the acute pulmonary irritants and the pathological conditions resulting from that. Know the difference between an upper airway irritant versus a lower airway irritant. And kind of like the cause of an acute respiratory distress syndrome. So it could be through physical trauma, or it could be due to an infection, or it could be to exposure to a lung irritant, and the clinical outcome of that. The pathogenesis of acute injury, and again, you have alveolar damage, you have pulmonary edema, lung surfactant problems, and this loss of type 1 pneumocytes that results in this alveolar thickening, which would reduce the gas exchange. Now, going from an acute lung injury, discuss the chronic responses of lung injury. So know the obstructive pulmonary disease with emphysema and bronchitis versus restrictive. Then we talk a little bit about asthma, the different types of cancers, right? So again, know the difference between obstructive lung disease versus restrictive lung disease, and talked a little bit about the what is the clinical definition of an obstructive lung disease, its features, its progression, and the pathological consequences, primary and secondary. So this is kind of like type A, which is emphysema and bronchitis. So just know the definition of emphysema, and then the definition of chronic bronchitis and the pathological definition of bronchitis. So again, this kind of shows the difference between type A versus type B, chronic obstructive pulmonary disease, and then chronic obstructive pulmonary disease in smokers. And then we switch from obstructive lung disease to restrictive lung disease. So understand what a restrictive lung disease is, and how it results in reduction in lung compliance, and how you would be able to differentiate that in the spirometry testing that we show like at the end of the lecture. Then we talked a little bit discussed asthma, the different types of asthma, all based on inflammation really results in asthma. And then cancer, so we talked about like different types of lung cancer, how it's an aggressive cancer, and how it's kind of on the rise compared to the other types of cancers. So we talked about, like, again, the small cell carcinoma, large cell carcinoma, adenocarcinoma, and squamous. So they're all very self-explanatory. So please know that different types of those cancers. And then gone into specific agents that produces lung disease. So we talked about the pneumocinosis, which is mineral dust exposure. So we talked about like silica exposure and versus asbestos, and the whole factors influencing the hazard, including like the mineralogy, the shape, the structure, and so on. And the intrinsic particle toxicity. So some of them could be fibrogenic, some could be carcinogenic, some can be inert, and so on. We talked about silica and how silica could result in silicosis, and then we talked about like asbestos, right? So crystalline silica versus asbestos. So to know like the mechanism of action of crystalline silica, how you would see it in a patient that got exposed to it in an X-ray, and the silica and lung cancer, right? Versus asbestos and the different class of asbestos, and then the pathogenesis of asbestos, and then how you, on a clinical setting, how you observe the effects of asbestos on in an X-ray. So again, this is kind of like differences between what you see in silica versus asbestos. So know the differences. And then beryllium, again, what is the chronic beryllium disease, the characterization of chronic beryllium disease, how do you screen and diagnose chronic beryllium disease. Bleomycin, I just wanted to throw in an example of a drug that you, or a chemical that you, in this case it's a drug that you don't take through inhalation but through oral intake, but results in an effect on the lung, and the mechanism of action of how it produces that effect on the lung. Paraquat is an example of another substance that you take orally. This is a pesticide that people obviously ingest on purpose to commit suicide, and how it can result in acute pulmonary fibrosis, and it's an acute effect, and the mechanism of action for that. So please remember that. And then at the end, what testing would you perform to identify whether or not your substance would result in a effect on the lungs? So we talked a little bit about spirometry testing and the spirometric measurements for lung volumes, where you look at forced vital capacity versus forced vital capacity in 1 second, and how you were able to differentiate between obstructive and restrictive lung disease. And then how would you use this ratio again to diagnose what type of lung disease you have. And this is kind of like an important slide, because again, you're showing here that your normal FEV1 value, you see a significant reduction with obstructive lung disease, versus with the restrictive lung disease, you're seeing more reduction in the FVC value. But when you get that ratio, you might be seeing an elevation of that ratio in a restrictive lung disease versus even the normal levels. Versus with an obstructive lung disease, you're seeing a reduction in this ratio. So that's kind of, again, important, and how would you able to distinguish between a restrictive lung disease and an obstructive lung disease using spirometry testing. And then with asthma, what you're doing is you are using the important thing is that it's transient and usually reversible, right? So if you administer a bronchodilator, you're going to see that the effects that you're seeing, the FEV1, is reversed. And you can also use some other spirometry measurement that requires like computer instrumentation to determine whether or not the patient is suffering from asthma. And then last, like within a preclinical setting, you could do the studies in animals or rodents and monkeys. And one key thing, if you're doing it in rodents, is, as a general rule, you don't want to put too many animals in the chambers, because that's going to have confounding factors on the results of the study. So that's a kind of a very important thing to remember. And when you're designing a study using rodents, that's something that you want to avoid. All right, so then shifting gear to the last lecture. So starting off again with endocrine disruptor, as I mentioned, there's not going to be that many questions, but know the definition of what an endocrine disruptor is. Know the examples of the endocrine disruptors I mentioned, right? So the pesticides versus the, triclosan as an antimicrobial, the effect of atrazine, demasculization, nonylphenols, the PCMs. There's going to be some questions on a few of those examples. Understand the assays that you would use to identify an endocrine disruptor, either using like the in vitro or the in vivo, and the tier 1 versus the tier 2, right? And how you would use that as a weight of evidence type of approach. Know the in vivo assays that I mentioned, so including the mechanistic eutrophic or the Hirschberger assays versus the pubertal female or male assays, as well as the intrauterine lactational assay. And as I mentioned, this is just an important slide in terms of that you have to take into context all the evidence from both the apical studies as well as the multi-endpoint studies, and come up with a determination of whether or not you have evidence of endocrine disruption. And that's why weight of evidence is important. And this is just an example of how you use that weight of evidence to determine that this drug is an endocrine disruptor. Just very quickly, that the environmental effects, I mentioned a couple of examples, and then the weight of evidence from epidemiological studies, and I mentioned two examples. One is this atrazine, the other example is the diethylstilbestrol that results in vaginal cancer. Risk assessment, again, there's going to be like maybe 5 questions on risk assessment. Just know the 3 pillars of the risk assessment: hazard, dose response, and exposure assessment. So well-defined risk assessment really looks at the, those 3 pillars. You don't take into consideration socioeconomic impacts or the perception of humans as the risk assessment. Those can come later on when you're trying to conceptualize it into a risk management or regulatory decision, but the 3 pillars of risk assessment is hazard ID, dose response, and exposure. Know how to calculate the reference dose. I can give you like a very simple example with no math required, right? No calculators. So if I say that you have a NOEL of 100, right? How would it's based on a chronic study in animals. First of all, what is the uncertainty factor you would use? The uncertainty factor would be 100 because you are using a study that's a chronic study, so you're extrapolating from animals to humans and humans to sensitive humans, so your uncertainty factor is 100. Now, what is the reference dose then? So you basically take that 100 and you divide it by 100, so your reference dose is going to be 1. Right, so if the NOEL is 100 milligram per kg, you divide that by 100, then your reference dose is 1 milligram per kg. So something as simple as that, just for you to understand the concept of how you derive a reference dose. And then I want to kind of talk a little bit about why the 10 and so on. The disadvantage of viewing a NOEL and using a reference dose. And then the carcinogenicity risk assessment and the whole concept that you derive a slope factor. From there, you come up with a probabilistic risk assessment to come up with a value to say what is the virtually safe dose that's going to result in cancer when you expose 1 million individuals that you don't want to exceed 1 individual getting cancer. So this is the whole 1 in a million type of risk that the agencies such as the EPA and is willing to take when they're doing an exposure assessment or risk assessment for a carcinogen. Just want to explain the just to put in perspective how you would perform a risk assessment on a chemical that has a threshold effect. So this here I just did an exposure assessment. Here I derived the NOEL value, divided the NOEL by my systemic exposure that I got from the exposure assessment. As long as I get an uncertainty factor more than 100, or a value more than 100, then that shows that I have an acceptable risk. This is just the carcinogen example, and again, how you derive a virtually safe dose from the slope factor that's based on the probability of causing risk of 1 in a million. So that's it. So that's kind of just, again, very quick overview about the 3 lectures. Again, there's going to be a final WebEx to answer any questions specific on any of those 3 lectures. In the meantime, if you have any questions, please shoot me an email. I'll be happy to try and kind of answer those questions in email. If you want to send me a list of questions before the WebEx, that would also be helpful, and we can discuss it live on the WebEx. So whatever you kind of feel is best way for me to kind of answer questions, please let me know. So I'll talk to you guys soon in the WebEx. Thank you.